So just click slide share and open your PPT.
Yeah, I'm again doing that.
Dr. Ashish, green button at the bottom.
I'm sharing screen. I'm trying to share screen once again, sir.
Open your PPT. That's right, sir. We can see it.
Now it's visible?
Yeah.
So 6-year female resident of Lucknow presented to us with chief complaint of fever and cough since 15 days. History was reliable as given by parents and the patient herself. According to father, patient was apparently all right 15 days back when she started to have fever. This fever was high grade with chills, intermittent, responded to oral medicine but used to appear again. This cough was dry, was not related to posture, with no diurnal variation. This cough was increasing in severity in last 7 days. So she was treated with oral drug for 7 days, but did not get relief. Then she was referred to our hospital. In the course in the hospital, patient was admitted in our hospital 5 days back and started injectable and oral drugs. Her fever improved, and she is afebrile since last 2 days. Frequency and severity of cough is also improved. There is no history of recurrent lower respiratory tract infection in the past, no history of fever with sore throat, joint pain in the past, no history of asthma, family history of asthma, no history of hospitalization in the past, no history of loss of consciousness, no history of prolonged fever, cough, or hemoptysis, no past and family history of tuberculosis. This patient has significantly past history, and it was, according to father, patient was diagnosed to have a heart condition at 1 year of age when she started to have episodes of bluish discoloration of face, lip, and tongue, which initially used to appear only on crying. But over the next 1 year, bluish discoloration appeared on the rest also. So in the past history, between 1 to 2 years, the frequency of episode was around 1 to 2 per week. Episode used to start typically with crying, used to last for around 1 to 2 hours, and subsided when she was taken in the lap and consoled. Between 2 to 3 years, she was received medical treatment for the same disease, same problem. Frequency of episodes decreased to about once in 2 months, but the resting bluish discoloration and distorted nail beds appeared. 3 years onwards, there was no episode, but she was appeared more blue according to father. She was also less physically active and fatigued earlier as compared to similar age group children. She restricted, at this point of time, she restricted her activity as compared to previously, but was able to do her day-to-day work like in the home. She was on regular follow-up with cardiothoracic department of our institute, where she was given medical treatment and advice for surgery for around after 4 to 5 years. In the perinatal history, this patient was product of non-consanguineous marriage, born by uneventful normal vaginal delivery, full term 2.6 kg, no history of any NICU admissions at that time. In the antenatal history, in mother, there was no history of fever with rash, lymphadenopathy, radiation, or teratogenic drugs. Only one antenatal visit was done, and there was no antenatal ultrasound was done in the patient. Developmental history, patient was normal for gross motor, fine motor, language, and cognitive parameters. Vaccination history, there is apparently vaccinated till 1 year of age, then there was no vaccination after 1 year. And patient is not on any yearly vaccination or routine vaccination. Family history, there's 2 older siblings, both are apparently healthy and doing well. There is no history of congenital heart disease in the family. In the socioeconomic history, family belongs to low socioeconomic status as per modified Kupusomi scale. So at this point, I would like to keep a differential diagnosis.
Please, can you summarize it?
Yeah.
This is a 6-year-old female who had history of diagnosed heart disease at 1 year of age, and bluish discoloration started at around 1 year of age, with history of spell-like episode between 1 to 2 years of age, which later on subsided, and his bluish discoloration of nail and distortion of nail clubbing was also there. Now she presented with history of 15 days, fever and cough.
You said something about the patient is being followed up in the department of CTVS at your institute.
The cardiothoracic department.
And the surgery has been advised after 3-4 years.
Yes, ma'am. Then they lost to follow.
Oh, so at what age was she told to have surgery done at after 3-4 years?
Yes, at the age of 1 year, she told you the surgery will be done around 4 to 5 years.
Okay.
At that
All
point.
right. So you have to keep that in mind when you are thinking about the various possibilities.
Yes, ma'am.
Okay.
What is the reason for fever? It is only a respiratory infection, or you are suspecting something?
At this point of time, fever and cough, we have to keep diagnosis of respiratory tract infection, which includes upper respiratory tract infection, lower respiratory tract infection, current era COVID type of infection, and we cannot rule out infective endocarditis at this point of time.
Say, are these type of patients more prone for respiratory infection or not?
No, sir. We don't expect these patients, especially
Why?
decreased pulmonary flow patient. They are prone to, as compared to normal population, cyanotic CSD patients are generally immunocompromised, so they are more prone to infection. But as frequent LRTA, we don't expect this patient in decreased pulmonary flow situation. If we're suspecting a decreased pulmonary flow situation.
Okay.
This list is based on your history.
Yes, ma'am.
So what is against classical tetralogy of arrows? Is there anything against? Because that's your one diagnosis, first diagnosis.
Yes, ma'am.
Agreed, it is the most common congenital cyanotic heart disease, but is there anything against that diagnosis in the history that you've said?
In history-wise, more than 50% or 70% patient get bluish discoloration by the time they reach 6 months or 8-9 months. 50 to 70% cases. Our patient presented after 1 year, and he started.
That may not be right, because parents sometimes don't notice, no, unless the history is significant. Parents may not notice. So what you're saying is desaturation starting at 6 months or something. But as when it comes to attention of the parents, it can be very late. It can be in years. So I don't think that's really classically against tetralogy of Fallot. That will be against any cyanotic heart disease for that matter. Even the others that you have listed below.
Yes, ma'am. Right. There's a possibility. And one point against is this: when they were advised surgery at 4 to 5 years after.
Yes, I think that's a very important point. If it is true, sometimes parents don't tell you the truth because they haven't come all these years, so they may put it on to the doctors. But if that is a true statement that they were not advised surgery at 1 year of age despite being blue, and were told to come back after 3-4 years, that will be very much against tetralogy of Fallot. No surgeon would say that.
Right.
So I would not put tetralogy from that perspective as on the top.
Right, ma'am.
Okay.
So there are the situations where you postpone surgery for 5 years, for not in
tetralogy situation, sir.
Yeah. In this patient, for example, if what the patient says is correct, so what are the situations?
Situation where classically tetralogy is postponed surgery in the older or 3-4 year age group, where in tetralogy there is pulmonary arteries are not good size. Then you put a shunt, and then you wait a shunt or RVOT stenting, and then you wait to pulmonary arteries to grow up for a size where you can do a complete 2-pump intracardiac repairs. One possibility.
So there also you would do something, it's not that you would leave the child alone.
Yeah.
Right, sir.
You would do a shunt, or you would do a stent, or some intervention. But which is the condition where you actually don't do anything? If the child is not too blue, you ask them to come back in a couple of years' time. Which could be.
One possibility is VSD and valvular pre-spleen when patient is not very blue.
So this patient is blue, not very blue, but this patient was blue at 1 year of age also. Despite that, the patient's parents were told to come back after 3-4 years. So of the diagnosis that you've listed, which one would you like to consider as most plausible? Do you have some colleagues with you?
Yes, ma'am.
Can they answer?
It can be a complex cyanotic heart disease.
Yes.
Supposing there could be a TG, increased pulmonary blood flow situation, which is unlike in our history.
No. We are talking of reduced pulmonary blood flow. So you have a list of single ventricle written over there. Why don't you talk about that? When do you do single ventricle surgeries?
So in this patient, if the patient is cyanosed and if the saturation is around more than 70% or 80%, we sometimes single ventricle physiology, we can wait for when the patient is ready to have a gland, like around
Yes.
1 year or 2 years, because most of our in Indian scenario, they prefer to do gland around 1 to 2 years, not
You
as
can even do a direct fontan at 4 or 5 years.
4 years.
Why not? Why not go for a direct fontan? In Indian scenario, you don't want too many surgeries anyhow. So
Yes,
very often, if the patient is doing well, has a single ventricle sort of a physiology, you can straight away go for a fontan at the age of 4 years or 5 years. So I think when somebody does it, come back in 3 4 years time, it's better to think of a univentricular physiology.
yes, ma'am.
So,
Okay.
do you like to keep single ventricle as the first possibility?
Unlikely, sir. I will keep a single ventricle as a lower possibility, except for the part that surgery was advised at 3 4 years, because one is prevalence wise. Second is at 6 year patient is apparently is not very high symptomatic classes. So I will still keep as a tetralogy type of physiology as a first possibility, with keeping in the mind that history may or may not be true.
What have you written below single ventricle? There are pulmonary atresia group, severe valvular PS with ASD, complex. Is it under the subheading of single ventricle, or these are separate diagnoses?
These first group I have kept is cyanotic congenital heart disease with decreased pulmonary flow, and
Okay.
second group
Okay.
pulmonary atresia group.
So pulmonary atresia group, you are talking of pulmonary atresia with intact ventricular septum.
Yes, ma'am.
That will be very, very unlikely to survive.
VSD pulmonary
Will not
atresia
make it to 6 years.
both groups. VSD pulmonary atresia.
VSD pulmonary atresia should come into the first group.
Yes, ma'am.
You know, all those conditions that you've listed, tetralogy, DORV, they can all be having pulmonary atresia also.
Yes, ma'am. But classically, top physiology, top physiology group, we sometimes keep VSD pulmonary atresia as a separate group.
Sure.
Sometimes they are included in the top physiology.
Sure. Okay. Okay. So basically, you don't want to consider increased pulmonary blood flow at all. You want to consider the decreased pulmonary blood flow group only.
Kept as a last possibility of complex cyanotic heart disease, where in rare possibilities, complex CHDs like single ventricle PH or TGA VSD PH, they get isomanganized very early without giving a significant history, and they sometimes behave. The cyanosis spell sometimes appears in history like a cyanotic spell, but they are just desaturating episodes. So, and they become isomanganized by the time they reach 1 or 2 years.
But then they won't be told that the surgery will be done in 3 4 years.
3 4 years. No, that is a very important history. That is negates whatever you have said now.
It is against the possibility. That's why I kept it as the last possibility.
What about pulmonary AV fistula?
Pulmonary fistula can be a possibility, but history of spell-like episode will be very unlikely in pulmonary fistula.
Yes, I think starting cyanosis at 1 year of age is very, very unusual, and history of spell is unusual. History of surgery at 3 4 years would be very unusual. So, although it's one of the diagnoses of cyanotic patient without heart disease, but I think very unlikely in this setting. Okay, go to the examination.
Right, ma'am. On examination, in general examination, patient was conscious, cooperative, thin built, sitting comfortably. Weight was 15 kg, which is between second and third centile. Height is 100 centimeter, which was below third centile. BMIs were 19.2 and no facial feature of dysmorphism. In vitals, pulse was 90 per minute, right radial artery, regular, normal in volume and character, no radial or radiofemoral delay. All peripheral pulse was palpable. Respiratory rate was 16 per minute, regular, no accessory muscles of respiration. Temperature was 98.3 degree Fahrenheit. Blood pressure was 92.78, sitting position right arm. No significant difference was in pressure in all four limbs. Right upper limb 92.78. SpO2 on room air, right upper limb was 78%. Left upper limb was 78%, right lower limb 80%, and left lower limb is 79%. SpO2 and 10 liter oxygen given for 10 minutes. For right upper limb saturation was no significant increase in the saturations.
What was the need of doing this oxygen hyperoxia study?
Because patient came with fever and cough, and we simultaneously we have seen the X-ray by that point of time. So we thought we have to give oxygen and see whether there is a respiratory component is there or not. Conjunctiva was normal, ma'am. Cyanosis seen at rats in oral mucosa, lips, nail beds of both the upper and lower limbs. Clubbing
Central
was
or peripheral?
central.
Equal
Central and peripheral both.
and equal?
Yes, sir. JP is 3 centimeter above sternal angle with normal waveform. No ascites, pedial edema or lymphadenopathy.
Again, you have to commit. Is JVP is elevated or not, like the previous case?
JP,
Just saying 3 centimeter for a 60-year-old may actually be elevated. So you need to commit whether it's elevated or not.
JP is normal for the 3 centimeter or not. Sternal angle with normal waveform. No ascites, pedial edema or lymphadenopathy. No peripheral sign of infective endocarditis. Vertebral column was straight. No bony chest deformity was there. In CVS examination, in inspection, chest was symmetrical. Trachea was central. No scar mark, dilated vein sinus was there. Apex impulse is seen in fourth intercostal space at midclavicular line. No visible pulsation was seen in precordian or epigastrium. In palpation, apical impulse is located in fourth intercostal space at midclavicular line. Diffuse apex of RV type. Systolic thrill present in left second third parasternal area. Liver was palpated 1 centimeter below right hypopoptum, which is within normal limits. Percussion left heart boundaries was corresponding to apex. Right heart boundaries were behind sternum. Pulmonary area was resonant. Liver dullness was on the right side. Stomach tympanic node on the left side. On auscultation, S1 was normal. S2 was single with A2 component. No S3, S4. In left third parasternal area, ESM of grade 4/6 was there. No additional sounds.
I think you need to describe the murmur better. No, this is really not the way. It's an ultra brief description of a murmur. And when you say second sound is single, how do you know it is A2? So you should not interpret it over here. You can interpret it based on your full examination, but please don't commit it to be A2. It could be P2, it could be A2 plus P2.
Yes, ma'am.
Also, you need to say whether it is loud or not. Obviously, there is one sound, so it's hard to say to compare, but at least you can get an idea about the intensity. So please describe the murmur properly.
So in left third parasternal area, there is long ejection systolic murmur of crescendo, decrescendo character, which is of grade by 4/6. And this murmur is heard all over precordium, mainly in the best heard in third and fourth area. Left third and fourth area.
Respiratory variation.
There's no significant respiratory variation.
So when you describe a murmur, you have to describe 6 things.
Yes,
even the pitch of the murmur needs to be described.
Yes, ma'am. Right.
Okay.
And there is no additional sound. There was no murmur on back, neck, and axilla. In the respiratory system, respiratory rate was 16 per minute. Bilateral air activity was equal. Bronchial breathing was there found on the left lung field, and there was crackles present over the left upper lung field. Other system examination normal.
Any pleural rub?
No, ma'am. No pleural rub.
Is it important to look for it?
Yes, ma'am.
Why?
In a pneumonia also we can have a pleural rub. We have to rule it out in a lower respiratory tract infection or any rheumatic.
No, not rheumatic. In a cyanotic patient who's come with fever, and you are finding some lung signs.
Ma'am, it can also due to LRT or due to embolism also.
Yes. Infective endocarditis is often on the right side in these cases, and therefore you may have emboli going to the lungs, producing pulmonary infarction, and that can give you an additional rub. So you have to specifically be looking for the rub. Okay.
In summary, is a 6-year-old female with past history of heart disease and cyanosis, along with a spell, presented with fever and cough for 15 days. An examination patient was found to have cyanosis, clubbing, right ventricle type of apex, no evidence of cardiomegaly, systolic thrill and murmur in left upper parasternal area. She also had a bronchial breathing in crackles over left upper lobe.
Did you comment on the left parasternal lift?
No, ma'am.
Is it there? Not there?
No.
So I don't know if you mentioned, but I don't think you did. You should. Even if it is not there, you should.
Was there a thrill?
Yes, ma'am. Yes, sir. Thrill was there.
Yes, sir. Thrill was there.
Thrill was there. Sir.
Okay.
I think you need to make a diagnosis, no?
Yeah,
Before you move on to ECG. What is your
What is
clinical,
your clinical
diagnosis?
diagnosis?
Yes.
So among the differential diagnosis, I will keep a cyanotic congenital heart disease with decreased pulmonary flow, with differential of, still I will keep a differential tetralogy of fellow and DORB VSDPS and PGA.
Tell me which congenital heart disease reduced QP it cannot be.
Yes, ma'am.
Which of the group of congenital heart disease with reduced pulmonary blood flow this patient does not have? Which disease, which congenital heart she does not have?
She will not have, ma'am, VSD pulmonary atresia intact septum, because there will be.
That is not in the group. You know, the group that you just wrote after the history, tetralogy of Fallows, DORB, VSDPS. No, there are 6 or 7 diagnoses in that group. Can you enumerate that group?
Yes, ma'am. First was classical tetralogy of Fallow.
Mm-hmm.
Second is DORB VSDPS.
Mm-hmm.
Third is TGA VSDPS.
Mm-hmm.
Fourth is single ventricle PS.
What else?
Or CCTG VSDPS can be in the tetralogy in the fellow in the group.
What else? 2 more.
AV canal.
And AV canal VSDPS.
Good.
Or plain VSD and PS can also be there.
What about tricuspid atresia?
Like
Atresia
single
type
ventricle,
1B,
I told, ma'am.
No, please don't confuse the two. Single ventricle, you can say univentricular physiology if you want to say together. But please remember, single ventricle is classically double inlet of a ventricle. It's not to be confused with mitral atresia or tricuspid atresia.
Yes, ma'am.
Those are absolutely separate entities which should be called as univentricular physiology because their management tends to be the same. But single ventricle is not tricuspid atresia. Tricuspid atresia is a separate disease and it is rather common disease. It's more common than TGA VSDPS in terms of survival.
Yes.
So tricuspid atresia is separate, single ventricle is separate.
Right.
That way you can have AV septal defect PS which has an unbalanced AV septal defect. That also will behave like a single ventricle because one of the ventricles is small. But please don't put them together. Single ventricle is different, tricuspid atresia is different. Single ventricle is classically DILV, double inlet left ventricle. That's the most common form of single ventricle. So which of these conditions, which of these diseases this patient is not going to have?
Yeah, she has said everything. Then given all the clues, then please.
See, you said RV apex.
Yes, ma'am.
Because
So tricuspid atresia and DILV VSDPS, both DILV kind of physiology, both will not be in the GD.
Yes, you must rule those out. You know, you have to go stepwise, ruling out one at a time. So whatever you can rule out by clinical examination, please put it aside. Then go to ECG. Maybe you will rule out some more. Then go to X-ray. It has to be like that. Don't depend on echo. Okay, show the ECG.
What was the what other negative finding in the lung examination you should have told? Did you mention continuous murmur?
Yes.
You mentioned.
In axilla and in back we have.
There is no
continuous murmur.
In the
Okay.
neck.
Okay. I didn't know. Sorry, sir.
Ejection systolic murmur at left parasternal, third and fourth area.
You said there is no murmur at the back. I heard that.
Okay. Sorry.
Yeah.
Okay.
Okay, go to ECG now.
12 lead ECG with normal standardization, showing normal
Where do
sinus.
you have standardization?
Yeah, there is no standardization.
Do you see it anywhere?
We cannot see. Yeah.
So then you can't comment. You can presume, but you can't comment. Okay.
I think it's not seen there, members. Okay.
Yes, it's not seen.
With a normal sinus rhythm, with right normal normal axis.
I think you should talk
Normal
about the
axis.
heart rate first. You must talk about the heart rate first. Go please stepwise.
Yes,
Otherwise,
ma'am.
in children, you will always miss tachycardia, no? If you don't look at the heart rate.
Normal sinus rhythm
Mm-hmm.
and with heart rate of around 100 per minute.
Okay, I don't see the small squares, but it's okay. Agreed.
100 per minute. With the right axis deviation.
We need to know the exact
That
axis.
axis, no?
Right axis deviation with around 120 to 130 degree axis. 120 to 130 degree axis with normal PR and normal QRS duration. Peak E wave in lead 2. PR and QRS duration QT intervals are normal. With in precordial leads, there is a dominant R with around 1.8 voltage of 1.8 with sudden transition in V2 with good LV forces in the V5, V6.
Can you rule out some more conditions of that group by this ECG?
Yes, ma'am. So,
Which one?
DORB, BSD, PS will not be having
Mhm.
a sudden transition.
Okay. No, access. I think it's more to do with access. DORB BSD PS has a far
AV
much more right access.
Yes, AV canal.
Almost AV canal is ruled out. Okay, very good. What else?
And
Tricuspid ATC is ruling.
I think that we ruled out clinically.
yes.
Also,
The Q waves you see?
And CCTG, VSD, PS is also ruled out because the Q in the V6 absence, it favors CCTG.
Okay. Single ventricle with PS, DILV?
Yes,
There will
ma'am.
be more predominant LV
Yes,
forces in the single ventricle.
Yeah, and even the X's tend to be X's and the like the precordial ventricular hypertrophy and X's don't go together. So there's a mismatch. Like you may have a left axis with right ventricular hypertrophy or a right axis with left ventricular forces. So there is usually a mismatch. Okay. So it favors tetralogy of Fallows.
Yes, ma'am.
Why there is a sudden transition in V2 in tetralogy?
because of ventricular because of VSD, so it acts like a window effect.
Okay.
So there is dominant R, but because of VSD there is sudden transition and followed by the ventricular septum, and because the LV forces are good, so V5, V6 R is of normal voltage.
Okay.
So, ma'am, both this and trabecular hypoplasia of trabecular both has been explained, though there is no clear-cut explanation for that. So both theories has been explained.
Would it be PS with intact ventricular septum with an AST shunting or a PFO shunting right to left producing cyanosis?
Yes, ma'am.
There would be transition.
That transition,
There will be no transition.
there will be no transition in those kind of situations.
What else?
There will be tall P-webs.
Gradient will be.
That might be a strain pattern in the.
So there is a strain pattern in V1.
Yes.
Which is odd for tetralogy. You have to say that.
Yes, ma'am.
Okay, go ahead.
So X-ray chest PA view with center film, no rotation, with slightly overexposed film. Abdominal situs solitus. Bronchus situs is also solitus. Levocardia with decreased pulmonary flow, levocardia.
It is almost mesocardia. I mean, you see almost equal amount of heart on both the sides.
Yes.
I think there is a bit of a rotation also. It's a very, very hard film, or not just hard. I think it's over penetrated also.
Penetrated, yes.
Over penetrated film. with decreased pulmonary flow on the right side, and also on the left side, but there is some infiltration seen on the left upper part, left upper lung part. In there is left heart border is not very clear, probably because of these superimposed lung infiltration, and there is right atrium is just borderline. It's not normal. It's not normal. It's looking more than the right atrium is little large as compared to the normal. Sorry, there is no cardiomegaly as far as now. There is left arch, left aortic arch.
What is happening to the left lung apex?
It is upturned, sir.
No. Lung.
So lung effect.
Upper zone.
There is
No, above that.
Yes, sir.
No, is the lung normal there?
No, sir. There is diffuse consolidation in the upper lobe and the mid zone, sir. There is consolidation. But there is also patchy bronchopulmonary infiltrate, sir.
Okay. So what about the vascularity? Is the same on both sides, or you cannot comment?
So one thing for sure, there's right side vascularity is decreased, and the left side vascularity, so the lateral 1/3 of the lung field is still dark. So I will at this point of time I want to keep decreased pulmonary vascularity on the left side, because these are more look like infiltrate with this background of examination. If this would X-ray would have been given to me without any background, then
now, what are the situations where you have difference in vascularity in a tetralogy like situation?
This is classically defined as pleuronemia, where left-sided, any of the one side increased vascularity is there. One of the commonest causes, if there is any shunt is done on the that particular side. One. Second, a big collateral which is supplying to that particular side. Or
peripheral PS also.
Yes.
Can.
Anything else?
What are the source of supply to the lung if there is a significant stenosis of the LV or RVOT?
There can be two supplies. Either
bronchial collateral. There can be bronchial collaterals. Or
is it a bronchial collateral or?
there can be a autopulmonary collateral, or there could be a PDA which can be supplying to that lobe.
So you can both coexist on the same side?
Sir, they can coexist, but then
they cannot coexist on the same side.
Sir, if they will, for example, if they supply to one lobe of the lung, both the duct and the MAPCAs, then
usually when there is a PDA, PDS and MAPCAs cannot coexist on the same side. They can coexist on the same patient. That is possible. But exceptions can be there, but that is the commonest.
Common association is that one collateral and one native supply is there. These are the common causes together, where you dual lung supply, one from collateral and one from the native pulmonary arteries.
I think if you're given this
yes,
you should probably ask for a better X-ray, because this X-ray is not really a good quality to interpret so much.
Yeah.
Definitely, the left side of the lung looks more plethoric. Maybe because of the parenchymal shadow, we don't know. But definitely, there is a difference between the two sides in terms of vascularity.
Right.
So, and you can barely see the cardiac shadow. So, I think this is not a good film to make too much out of it. You could probably safely say that there is no cardiomegaly, and the pulmonary vasculature seems to be overall reduced. That's all information you can get.
Interrupting, the discussion is really absorbing, but time is running out. We have only 7 minutes left.
Sir, I was waiting for your interjection. Please go ahead.
Coming to echocardiogram, showing subcostal views, which showing aorta, pulsatile aorta on the left side and IVC on the right side, cystoscopy of abdominal situs solitus, and subcostal bicaval views showing SVC draining into RA, and sweeping from right to left, showing that IVC is on the right side and aorta is on the left side. Subcostal tipping of view and short axis view, showing two good sized ventricles. This is LV and this is RV, and we can see here the aorta.
Are you a pediatric cardiologist?
Yes.
Okay, no, I'm just wondering, the adult cardiologists may not be very comfortable with this.
I think he did his training. He did his training in pediatric cardiology from the south.
It is the other way around. Yeah, go ahead.
You can see the LV and RV, both good sized ventricles, and we can see the aorta rising from LV, and there is significant overriding is there, and we can also see in the lower slide that.
I think show us in other, the parasternal views, please.
So this is the 4-chamber view showing good size of LV and RV cavity, and mitral valve and tricuspid valve score was -0.5. And this 5-chamber view showing aorta arising from LV with around 50% override. We can see the large VSD here, and we can see bidirectional shunting here, and this aorta is around 50% overriding, we can see here.
The best view for saying the degree of override is a parasternal long axis view. Here you may get a little bit of modification, and therefore you may not be able to assess very properly. But if you have a proper parasternal long axis view, that gives you the override degree much better.
So this is a parasternal long axis view showing large subaortic with bidirectional shunting, and here you can see the critical override efficiency.
Yeah, but you can see the override is much less than what you thought.
It is a little overestimated in that view.
Yes.
And this is parasternal short axis view showing pulmonary artery arising from RV, and there is significant turbulence in the RVOT, and pulmonary arteries are confluent.
Can you freeze the Doppler across the RVOT in the right lower panel? Just show that. No, I just want to see the Doppler, and I want to ask you some question on that.
Stop.
Maybe just a frame before where you were seeing two signals.
Stop.
Oh, yes, that is the one. So what does this tell you?
Infundibular as well as valvular obstructions.
No, that is okay. How much infundibular and how much valvular?
Gradient of around 50 in the infundibular region.
Almost all is infundibular. Your infundibular signal is almost reaching where the total signal is.
Yes, ma'am.
So it's this almost, and you can see that on your two-dimensional echo as well. That your pulmonary annulus pulmonary valve looks pretty good. All the turbulence is happening below the pulmonary valve. So it is almost all is pulmonary.
Obstruction in the infundibular region, ma'am.
Yes. That's very well seen on your Doppler. And it is important because many times when you have pulmonary stenosis, intact septum patients, and you are not sure how much is infundibular, how much is valvular. I'm talking of pulmonary stenosis plain, not VSD pulmonary stenosis. And then you don't know whether to dilate them or not. So this really helps to know how much is infundibular and how much is valvular. In tetralogy, you expect dominant of infundibular anyhow. So I think.
And here the RPA and LPA was 7 mm each with a G score of -1.4 and -1.
What are the other methods to scorings to assess the pulmonary artery size?
So it could be Nakata index, it could be Macron index,
or total neopulmonary artery index.
Okay. Go for it.
Okay. Next
is parasternal view showing aortic arch with left carotid and subclavian arteries.
So it's a normal arch.
Yes, ma'am. And there was normal coronaries also. We still frame we could not retrieve because of some COVID issues, ma'am, in the lab.
Okay. What do you want to do now for her? Okay, this is the final diagnosis. All right.
So coming to final diagnosis, I will commit on situs solitus, levocardia, cyanotic congenital heart disease with decreased pulmonary flow with tetralogy of Fallow, with good sized pulmonary artery and annulus with normal lateral great artery, left aortic arch, good biventricular function, in normal sinus rhythm, no evidence of heart failure, infective endocarditis, NYHA functional class 2 with lower respiratory tract infection with left upper lobe consolidation. With this diagnosis, ma'am, I would like to again repeat the X-ray after 1 week of antibiotic. I want to be doubly sure that this is not because of increased QP, and if the lung this subside and this is clear-cut a case of left lung also decreased QP, then probably intracardiac repair will be the best option for her.
Now you had some difficulty in assessing the vascularity on both sides. Now, what other investigations will you do before sending the patient for surgery?
One is, sir, we'll go by, if vascularity is an option, is a doubt, then we can go for both CT and cardiac catheterization. With cardiac, with a 6-year female and surgery is planned, maybe the cardiac catheterization will offer, though this is not absolutely compulsory.
Now, what is the problem in having for example, you said there is some increased vascularity and there is a MAPCA probably. What is the problem in surgery?
Major problem when we have a MAPCA, a large MAPCA to the one side of lung, because these lungs are used to decrease QP, suppose 0.5 to 0.7 or 0.3 QP. So once you operate them and made an intracardiac repair, these additional QP will create post-operative, these additional MAPCAs will flood the lung and patient will never come out of the ventilator after post-bypass.
No, these MAPCAs are here now also. They are there. So if at all, they might actually come down in size once you establish antegrade flow, the MAPCAs may actually reduce in size.
Yes, ma'am, they will usually reduce in the size, but large MAPCA.
So is there any other issue that you think MAPCAs can create, and that is why you are keen to know whether they are there or not?
Bleeding, ma'am.
Bleeding when? Where?
When is the bleeding?
Bypass. During bypass.
Yes, so you have to say that it's not bleeding. I think you have to use another word. What happens during bypass if the MAPCAs are still there? You want a bloodless field, isn't it?
So with blood to the field and the total circulatory arrest which we want.
So the blood will keep coming back into the left atrium because ultimately it goes to pulmonary veins, no? Pulmonary artery, pulmonary veins, and it will keep coming to the left atrium, and will interfere with surgery.
It will interfere with surgery, right?
So that is one. In the post-op period, yes, they can bleed also. That is also right. But I think in a 6-year-old, you should probably do one of the imaging, either a CT angio or a cath, before sending for surgery.
Should be done, I think.
Yeah, I think CT angio will give practically all the information. There are two important pieces that you might miss by echo. One is coronaries. You might have seen it, but I think you have to be more clear at 6 years of age. The echoes are not so good. And second is the collaterals. Even if there is good antegrade flow like a typical tetralogy, at 6 years you expect some collaterals to be there, which might give trouble during surgery, and therefore they may have to be looked after pre-operatively. So one imaging is definitely required, and perhaps a CT angio is the best way to go about it.
And it will also give information about the pulmonary issues. It can give some information.
Definitely, yeah.
Will you follow up this patient after surgeries? For example, you didn't find any collaterals. You did the surgery. So patient was this. How will you follow up this patient?
So in the follow-up, we will first on the echocardiography. In the echocard, we have to see which kind of surgery they do. In this kind of substrate, I expect a wall preservation surgery, and I think the transannular patch is not required. So in the follow-up, we have to see any residual VSDs are not there. One. Second, amount of pulmonary regurgitation is there. How much amount of pulmonary regurgitation is there? If significant pulmonary regurgitation is there, patient need to be on continuous regular follow-up.
MRI is the standard of choice. Yes. It is the gold standard for follow-up.
Yes. What are the long-term problems of post-TOP surgery patients?
RVOT aneurysm may develop. There may be RVOT aneurysm.
I think we should end here.